Hi, everyone. Marina Kurian. Thank you to the SAGES program chairs for allowing me to discuss this topic, which is using post-operative pharmacotherapy to avoid obesity, recidivism, what and when. So let's get started. So these are my disclosures. They are not relevant to this discussion today. And I think when we talk about recidivism, there are multiple different definitions. What I consider recidivism versus somebody else, but there are actual definitions that are fairly arbitrary used for publications. And they're also different for when we as surgeons can do any kind of intervention to restore a failed procedure like a dilated pouch or gastrojejunostomy or a dilated sleeve versus what the insurance companies will actually pay for, and when they consider the criteria to be appropriate, and that's usually that they've regained, to a BMI of 40 or meeting the original criteria of weight loss surgery. So there's been stuff written about all these different stages. When does it start? Is there a way for us to identify patients pre-op that are not going to do well with weight loss surgery or may regain weight? You all know the answer to that. It's unlikely that we find one item that's going to definitely say, okay, this person is definitely going to regain weight, will need additional help. Intraoperatively, we've discussed bougie sizes. Is the pouch too big when you first started? And all these things can impact. But then there's also early post-op when you're seeing the patient and you see that they're actually not losing as much weight as you expect. And so you delve into their eating habits and their activity level and see what's going on. And then there's late post-op, which can also happen when people are stressed or they're falling back into bad habits, and they might need an intervention then. What I'll say for each and every one of those stages is that there's no shame in medication. Everyone can use a little bit of help. And this is a list of all the medications that are out there. And I'm going to go into each one of them separately, but they do help the patient. And sometimes our patients come in on the medication and other times not. So these all will help long-term. So my strategy, again, intervene early. I do it at the first fall off. So if I see somebody at between 3 and 6 months and they've only lost 2 pounds in the first year of a weight loss procedure, I know there's something up, right? So I will ask them about diet and exercise and try and figure out what it is, how we can help, and I will talk to them about medications even that early. Now, if they're, say, a year out, and my patients, a second year, I ask them all to come in every 4 months, second, third, fourth year. And that's just to make sure that they're staying on track. And it's a nice check-in for both of us, and it keeps both of us accountable, the patient and the surgeon. So I will, at the first sign of weight gain, again, diet, history, activity level, type of foods, and then I will medicate them as well. The other thing that I think is very important is I increase their frequency of visits when I see that they're not doing well. I think that needs to be done. So sometimes once I medicate them, I always see them 30 days later. And then if they're doing well on the medication, I'll go to 2 months. But some patients need to be monitored a little closer. And some of them will tell you that they want to be seen more often. So again, do a lot of education, go back to the rules, no eating and drinking at the same time or for 30 minutes after a meal. I review their dietary plans with them. I really like low processed carb diets. I think that they are key to our post-op patients. Keto, though, can work, even with bypass and with sleeve. Keto does seem to work. And I'll ask them to combine either low carb and intermittent fasting or keto and intermittent fasting. And there are a couple of different ways to do intermittent fasting. One is the 16-8 method, where you're only eating for 8 hours a day. And the other one that I thought would be easier for patients to do is the 5-2 diet, where 5 days a week you're on 1,000 to 1,200 calories a day, and 2 days of the week you're on 600 if you're a woman, 800 calories a day if you're a male. And that 5-2 diet is something that I also ask patients to try and follow. And for our post-op patients, the 5-2 does make sense because they're used to doing just shakes. And so on those 2 days, they can do just shakes, and it seems to be pretty well tolerated. I can't say that I have patients on that long term, so it's a little bit complicated, but they can also do the intermittent fasting, and that might work as well. And then I medicate as needed. So that is definitely something I do. So where do you start? You have a patient come in, and I look at their history. I try to pinpoint where is the problem. Is it cravings? Is it choice of foods? I try to get them on the diet I want them to follow, and then I'll add medication, and I look for any contraindications to within their history, or whether they've had certain meds in the past and have had side effects from it. You'll find that when you start medicating your patients, you're going to have your favorite workhorse or two. I have two that I like to go to all the time. One is the phentermine topiramate. I think it works wonderfully. And also just regular phentermine works, and depending on the dosage level and depending on the patient. The other things that impact is very important is the cost to the patient. Many times our patients cannot afford huge copays, and sometimes insurances are terrible and they don't cover at all. And so these factors will play into what the patient can take. And then there is the off-label use of medications. I will be talking a little bit about that, but off-label use in terms of medications that will give patients weight loss, but it's not exactly why they're supposed to take the medication in the first place. So again, this list of meds, these all can work. Many of our patients already come in on metformin, either for diabetes or prediabetes, or for PCOS. And actually, sometimes there are primary care docs that will prescribe metformin for the patients to help them lose weight. These are the doses of phentermine that are available. The 15 and the 30 are capsules. The 37.5 is a tablet. And that means that sometimes when patients need more than the 15, you can give them the 37.5, just slightly more, but they can take it a half one day and a whole another day, which is important if they have side effects from the phentermine, which I'll get into in a little bit. One of the newer, the next three are the three newest drugs that were approved by the FDA. So phentermine topiramate, which I think works for most people. Naltrexone Wellbutrin, which is a tablet form, and it's 2 pills twice a day. Phentermine topiramate is once a day pill dosing, which is really easy. And then liraglutide is a daily injection, and we'll get into that. And then, of course, there's off-label use of other GLP-1 agonists that have the side effect of patients losing weight, but are on label for diabetes or prediabetes. And then you can also prescribe naltrexone alone or topiramate alone for weight loss. So pros of metformin, it's been around for a long time. Antioxidant and anti-aging effects is a bonus side effect of metformin. You start with 500 once a day for a week, and then you can go up higher dosing. And I say you can expect no weight loss to about 15 pounds of weight loss. The patients have seen very variable results with the metformin. The con is that the patients will experience diarrhea or may experience diarrhea for the first week. And sometimes they'll also, if you increase the dosage, they'll also experience diarrhea every time the dosage changes, but it usually only lasts a week. So you need to try and tell them that, warn them, and get them to stick to the medication. Phentermine has been around for a long time, and it's an appetite suppressant, and its doses again are anywhere from 8 milligrams a half hour before meals 3 times a day, or to 37.5 milligrams once a day. I tend to start low and then I go higher. I do get an EKG before starting the medication, and you can expect about 5% total body weight loss. But the interesting thing about phentermine is that we have some super responders. And then we also have some people that, you can dial up to the highest dose and they may not respond as well. And you might only see like 2% total body weight loss. Cons are you have to be careful with any kind of heart disease. You have to watch with a lot of mental illness, and anxiety can worsen. You have to be careful in bipolar patients. Many times if the patient's on a lot of meds, I will call their psychiatrist and speak with them, and we come up with the medications that they can take together. So something to consider. Patients can feel jittery, sleepless, they can have palpitations, and so some of those side effects limit when and how high the dose you can prescribe. So the next is phentermine topiramate. It comes in several doses, which is great. The first dose, the 3.75, is a test dose. You give it to patients for 2 weeks, and if they don't have side effects, then they take the actual dose. It's great because it's once daily dosing. Patients like it, there's ease of use, and it usually has excellent compliance. It has appetite suppression and satiety, and you expect about 10% total body weight loss at 6 months. The cons are dry mouth, jittery, feeling jittery, sleepless. They can have palpitations at the higher doses. Some patients also know that they feel a little bit foggy, and that is a side effect of the topiramate. And the cost is, if insurance doesn't cover it, is about $120 to $160. And that can be prohibitive for some patients. You can also break out the phentermine and the topiramate separately, but the combo pill really does work better. Naltrexone Wellbutrin, it has 8 milligrams of naltrexone, 90 milligrams of Wellbutrin. Expect about 10% total body weight loss at 6 months. It's still a little bit cheaper. It's about 90 to 100 without insurance. So that's why this might be a go-to for some people. It's good for cravings. And I also think that the Wellbutrin really helps address undiagnosed depression. You have to be careful though with other psych meds. And so this is again where I'd reach out to the psychiatrist and have them switch out other antidepressive meds and we'll go up on the Wellbutrin. Some patients are already on Wellbutrin, so the deal with this naltrexone Wellbutrin combo is that you have to go up to 4 pills a day. So you start out with once a day for a week, and then 1 twice a day for a week, and then you go up to 2 in the morning, 1 at night for a week, and then 2 and 2. And so that is takes about 4 weeks to do. You can, if someone's on Wellbutrin already, you can have their dose of Wellbutrin and add 1 pill. And then once they get up to 2 pills a day, you can stop the Wellbutrin, or you can check with the psychiatrist and work with them on the dosing. Patients sometimes tell me when they start the medication that they stopped it because they felt like they were taking something or on something. And I'm always like, you're taking medication, but it gives them a feel weird type of thing, and they don't feel like they can tolerate it. Constipation is also a big side effect. Obviously, for all these medications, there are other side effects that you'll become familiar with, but these are the 2 main things that I see. And surprisingly, I've had some patients who have high blood pressure on 2 or 3 meds develop worsening high blood pressure after a while of being on this combo med, and it is felt to be due to the naltrexone, which was a surprise, but sometimes you can wean them down and then go back on, and it's maybe not as high a dose, and the blood pressure is managed. Liraglutide is the only medication that is FDA approved for weight loss as a GLP-1 agonist. So the pro is that you can dial up the pen to multiple different dosages. The highest is 3 milligrams, and the dosage, if the 3 milligram is too much for the patient, they have too much nausea or too much GERD, you can dial it down to the lower dose, so that's nice. There's a range in there so that you can treat for symptoms and weight loss. You expect at 6 months about 10% total body weight loss. It modulates insulin sensitivity, decreases gastric emptying, so the patient feels full longer, which is wonderful. Cons are constipation, and some patients experience severe GERD, and you cannot prescribe it in patients who had a personal history of pancreatitis or familial history of medullary thyroid cancer. And thankfully, that last exemption is really a small percentage of patients. The other GLP-1 agonists have the same limitations in terms of pancreatitis and medullary thyroid cancer. You can give these on label to patients with diabetes and prediabetes to help assist them with their weight loss. Otherwise, it's considered off-label use. And you see variable weight loss depending on which one you pull, of about 3 to 5% total body weight loss, but there are super responders. And I do believe that the semaglutide in all of the studies has shown the best outcome in terms of weight loss adjunct. And the cost is variable, again, depending on insurance coverage, but you know, liraglutide, if it's not covered, it can be $1,200 a month, and semaglutide, if not covered, can be $800. Dulaglutide is about $700 a month. So these are very prohibitively expensive. Thankfully, most insurances will cover them if they have appropriate indication. So let's do some scenarios so you kind of see how I do it, and know other people might do it differently. You have a 44-year-old patient. She had a sleeve a year ago, and then from her 3 months to now, she's only lost 4 pounds. So I review all the meds, the diet, her activity level. I do ask her to keep a food log. I do a 24-hour recall of the food. I ask them what they feel like their worst food choices are. And then I would probably start this patient on a low-dose phentermine. It's affordable, and we'll see how she does. I bring them back in 30 days. If there is weight loss, then I will do the same dose unless the patient's telling me, you know, I don't really feel it as much now, and then I'll increase the dose. And then if I increase the dose, I see them monthly. But if it's the same dose, I'll bring them back in 2 months. And I could also start this patient on Qsymia or Contrave. Both would work. Because based on what I've told you and shared with you, she doesn't have contraindication to any of these medications, and I can do it. The reason I don't bring these patients in monthly forever while on the medication is I'm still a surgeon, and I don't have the time in the day, and neither does my nurse practitioner who works part-time for me. We would not have enough slots to see all the patients, so we bring them in every 2 months. Okay, this is a 44-year-old, had a sleeve, lost 4 pounds from the last visit, but she has diabetes. So again, I go through the whole thing, look at her meds, her diet, her activity, look at the food log. Now, because of the diabetes, I will start on a GLP-1 agonist. I'll bring her back in 30 days. And if there's weight loss, I'm going to keep the same dose. I tend to, with the GLP-1 agonist, keep the same dose until I see that they're not losing, and then I'll increase them to the higher dose. I could also start this patient on Qsymia or Contrave, but the GLP-1 agonist is wonderful. And again, same patient. It's so great to have the same patient, but she has severe hypertension and atrial fib. Same deal, look through everything. I cannot put her on phentermine or one of the combo meds because of or naltrexone. So it puts off the phentermine topiramate, it puts off the naltrexone Wellbutrin. So for this patient, I may put them on Wellbutrin or topiramate alone, and then I might be able to add a GLP-1 agonist off label, depending on the patient's circumstances and insurance. I could add it after 30 days, and that would probably work. I'll bring them back again every 30 days, and anytime I add a medication, I see them again in 30 days and follow them out every 2 months once I have them on something stable. Should not be afraid to layer therapy. So GLP-1 agonists and phentermine work really well together. I have patients on Qsymia, and I'll add a GLP-1 agonist, so it's not just straight phentermine. I'm going to give you an example of 2 patients that I started layering a lot of meds on. One is 51. She had balloon therapy, and once I removed it, I had her maintained on Qsymia for a long time. She lost her job, her circumstances changed. I had to start adding other meds, so I added naltrexone and then ultimately added semaglutide, and now I see her every 2 months for this medication regimen, and she is maintaining a stable weight. And then we address her diet, etc., to try and to encourage some further weight loss. But there's no weight gain, which is a boon. So now I have a male who's 15 years after gastric bypass and was gaining some weight. I put him on phentermine. That worked for a little while. Then it stopped working, so I added Belviq, which is not available now. But Belviq, we were calling it Belfen. Those two were like a less risk adverse version of fen-phen, but now Belviq's off the market, so it's anyway, he's not on that. I added naltrexone for his cravings. And I also put him on a GLP-1 agonist, which is dulaglutide or Trulicity. So there are a lot of options that we have to sustain or have further weight loss in our patients, and patient history of comorbid conditions, medication history, as well as the cost of meds impact the patient options, what they can afford, and what might work well for them. Intervene early. Do not be afraid. If they are not on your projected trajectory of weight loss, then get in there and give them something to get them back on track. Increase your frequency of visits. Again, it gives you accountability in terms of taking care of the patients and maximizing their outcome, and the patients are accountable because now they know they're going to see you, and it'll help them to stick to the plan you've devised. Don't be afraid to layer the therapies, but I got to say, those last two patients, it's kind of why I got my diploma of the American Board of Obesity Medicine, because once you start layering meds and you're a surgeon, you kind of, I started to feel like maybe was I out on a limb, and so I got the obesity certification to try and help me understand when I was layering the meds, how they would work, and to make sure the patients were doing great and I was doing my best for them. So thank you very much for the opportunity, and bye.